Assalamu alaikum wa rahmatullahi wa barakatuh. In this session, we will apply practically and we will take cutaneous wound healing as an example of wound healing. Well, cutaneous wound healing is the process by which a wound is eventually replaced by both epithelial regeneration and connective tissue scar. This is a wound in the skin of the finger. Let's imagine that this is the wound in the skin this is the epidermis and this is the connective tissue. Sometimes the injury is small and doesn't affect the basement membrane, while others the injury is great and affect the basement membrane. So the epithelial layer will be regenerate continuously to form a full epidermal thickness, normal, because epithelial cells are able to regenerate. So they exclusively healed with regeneration, while disruption of the basement membrane and the extracellular matrix of the underlying connective tissue will lead to formation of scar tissue, that's to say healing with laying down connective tissue. So as a whole, the process of wound healing is composed of both epithelial regeneration, because epithelial cells are labile cells, and connective tissue scar. Destruction of the epithelium only is termed an erosion. Look, this is an erosion because no disruption of the basement membrane. However, disruption of the epithelial layer while reaching deep into the connective tissue is called ulcer. So erosion heals exclusively by regeneration. Why? Because the basement membrane is intact. Only the superficial layers is injured and it can easily regenerate and restore to normal. However, in such case, where ulcer or disruption of basement membrane and reaching into the deep underlying connective tissue, this is called, if destruction of the basement membrane occur, that's to say extracellular matrix, then a scar will form according to nature of the wound. تمام? So healing occurs. In such case, healing occurs through first intention and second intention. Let's see together. Here is a wound. Here is a wound. This is the epidermis and this is the wound. Look. This is the epidermis, epidermal layer. Do you agree with me? And so on here. The first thing that occurs after injury is extravasation of blood. So blood comes into this space and getting on the surface to form what's called crust. This crust actually is important for two reasons. The first one is that it keeps the two edges of the lesion adherent together as much as possible. So it looks like this. Look, this edge is approximated as closer to this edge as possible to minimize the area of loss or tissue loss, and of course later on to minimize the area of scar formation. However, this blood clot will hinder this approximation. The body, how does the body deal with this? Actually, the cells here release, and the macrophages and the blood elements release growth factors and cytokines that recruit neutrophils. Yes, neutrophils come to the site of the injury. And here and phagocytose this blood clot. Again, growth factors cause or lead to recruitment of macrophages. Recruitment of macrophages. And again, macrophages release factors that degrade the fibrin and ingest the blood clots. Well, afterward, the tissue could be easily approximated either naturally by the overlying crust or by suturing, surgical suturing. Well, then the epithelial layer migrate and proliferate to close this gap. Again, I will here just to clean the spaces here. Yes, the blood clot is totally digested and no more blood clots here. And this is the epithelial layer, the crust. This is the crust. And the epithelial layer began to regenerate here and close the gap like this. Well, I just want you to apply what's happened in this gap here, but I couldn't draw everything in this line, so I will draw it in this photo. Well, the neutrophils bring macrophages, as we said. Neutrophils bring macrophages. And these are neutrophils. A little bit. Macrophages and mesenchymal cells will trigger angiogenesis process. As we told before, this is a nearby blood vessels will be a source for newly formed RBCs. So the RBCs enter here and here to supply the wound by the proper oxygen and nutrient. That's good. Here is the beginning of granulation tissue. So first of all, blood clot, the stage of blood clot, and digestion of the blood clot with neutrophilic infiltrate or neutrophilic recruitment, neutrophil recruitment. Then the macrophage comes. Then epithelial cells regenerate. Epithelial cells regenerate over the surface and close the gap. That's nice. Number 4, new vascularization. New vascular macrophage also plus neutrophils and macrophage recruitment occur. Number 5, new vascularization and beginning of new vessels and beginning of granulation tissue formation. And let's say the rest of the story, new vessels will attract fibroblast. Fibroblast will come. After the fibroblast come, there is collagen deposition. You have a fibroblast, then collagen deposition, and collagen remodeling of the wound. Remodeling of the wound. Well, this is the usual steps of wound healing, of cutaneous wound healing. However, I need something. I need some precautions. First of all, I need the two edges to be approximated together like this. Is that right? So, in order to accelerate the healing process, in order to minimize the scar tissue formation. So, this is number 1. Approximation of the edge or wound. We could approximate the two edges of it together. That's nice. And in order to approximate the two edges together, we need little amount of tissue loss. يعني not that type of injury. Look, this injury, there is great amount of tissue loss, However, here we couldn't approximate the two edges, but here we could approximate the two edges. So here, scar formation is much little than here in this type. Okay, this is number one. Number two, I need to approximate the edges, and maybe I need to suture it. What if there is bacteria here? There is bacteria. Could I close the wound? Of course not. I couldn't close the wound. Why? Because if I close the wound, it will create an anaerobic environment for bacteria to grow, and I don't want that. So if the wound is infected, I couldn't approximate the edges, so the healing will take longer time and much more tissue loss. Well, the second issue, what about if there is a necrotic material, necrotic tissue, or a foreign body material, like this? Could I approximate the edges and close the wound? Of course not. I should keep it open, like this. And first of all, I should debride the necrotic tissue, remove the necrotic tissue, search for foreign body, and remove it. So otherwise, I could approximate the two edges. But if I couldn't do this, if I couldn't remove the necrotic tissue, I couldn't remove the foreign body, or this could take more time with me, again, the healing will take more time and the tissue will be gapped with more granulation tissue formation. With me or not? Okay. This type of healing called primary intention. Healing with primary intention. Well, however, this type of healing is called healing by secondary intention. That's nice. Let's revise the difference between both of them. Both of them are composed of regeneration and connective tissue formation or scar formation. Regeneration of the overlying epidermis and scar tissue formation of the underlying. However, the scar tissue for the space in primary intention, the space of tissue loss is small in comparison to the secondary intention. There is no infection. The wound is clean, no necrotic tissue, no foreign bodies in primary intention. However, in secondary intention, there may be foreign body or necrotic tissue or bacteria. Okay, primary intention will lead to a little amount of scar formation, while secondary intention will lead to a more amount of scar. In secondary intention, actually, the epithelial layer couldn't approximate properly and take more time. So we have to pack the lesion, and every now and then remove the pack and perform proper irrigation and proper antibiotic ointment and so on to keep the lesion or the wound clean and disinfectant. So the pack here is important to keep the underlying tissue wet. Why we need the underlying tissue wet and not to be dried up? Because if the plasma or if the cells edema in the granulation tissue is formed, is dried up, the cells will eventually die and the healing process will eventually delayed. Okay, is that clear till now? So let's apply this on the coming slides. What is primary intention? The injury causes only focal disruption of epithelial basement membrane. Focal disruption of epithelial basement membrane continuity and death of relatively few epithelial cells and connective tissue cells. That's to say, small injury. Examples like surgical incisions, in which there is a clean, uninfected wound. Clean, uninfected wound. well opposed edges, حتى even if we use sutures, and minimal cell and tissue loss. Well, while in secondary intention, the injury here, while in secondary intention, the injury here causes wide disruption of epithelial basement membrane, continuity, and large volume of necrotic dead epithelial and connective tissue cells. For example, large gaping wounds with unopposed edges not approximated by sutures, such as abscess. Yes, of course, abscess will heal by secondary intention because there is extensive tissue loss, there is infection, we couldn't get the two edges of the lesion opposed together. Ulcer, the same applied, external injury that destroys extracellular matrix. The wound slowly fills with granulation tissue. Yes, this is a wound, and it's slowly filled with granulation tissue from the bottom up, from the bottom up. A large scar usually results. Here the same steps we mentioned before, however with time schedule. Immediately, blood clot seals the wound like this. After 24 hours, neutrophils increase at the margin, while from 1 to 2 days, epithelial cells proliferate and migrate from both edges with deposition of basement membrane-like material. Day 3, granulation tissue, macrophage, collagen are vertically oriented. On day 5, new vascularization. In its peak, collagen fibers begin to bridge the incision. Epidermis equal its normal thickness, and the epidermis reach the normal thickness. On week number 2, collagen deposition continue to accumulate. Edema, inflammation, and vascularity decrease. That's to say, there is transformation of the granulation tissue into fibrous scar. After 1 month, a fully developed scar is eventually seen. Collagen bridged the incision and covered by thickened epithelium, no more inflammation, no appendages at the incision. Of course, no appendages at the incision because the appendages, we mean by the appendages the hair follicles, the sebaceous glands, the sweat glands, and so on. All of these things are lost because all of the injured area are replaced by fibrous tissue, and fibrous tissue is not a carrier or is not a suitable site for regeneration of these appendages. Well, in secondary intention, it's the same. However, it takes more time and with more tissue loss and more scar formation. So we usually, our wounds usually healed by secondary intention if there is necrotic debris, if the tissue defect is large or fibrin clot is large, if there is excessive inflammation, and so on. Here is a difference, a comparison between primary intention and secondary intention. Number 1, cleanness of the wound. Of course, the wound in the primary intention is clean, while in the secondary intention could be not clean. Infection, the primary intention usually is not infected. However, in secondary intention, it may be infected. Inflammation, in the primary intention, it's mild, while in the secondary intention, more intense. Granulation tissue, scanty in primary union, while in secondary union, of course, secondary union means secondary intention. Much larger amount is formed of granulation tissue. Okay, and scar formation. Scar is contracted after it's developed. So the less scar, the less contraction. The more scar tissue, the more contraction. So we can expect more contraction with secondary intention, while there may not be at all wound contraction in primary intention. Outcome, neat linear scar, while in secondary intention contracted irregular scar. Complications, infrequent epidermal cyst, but in the secondary infection, the complications is more frequent and mainly suppuration, and we will talk about complication later on in details. Time needed for healing. Actually, the primary union or the primary intention need less time, while the secondary union need more time and care. Let's talk a little bit about granulation tissue formation. Pink, soft, granular. What is granulation tissue? It's a pink, soft, granular appearance on the surface of the wound, and it appears by the 3rd to 5th day due to proliferation of fibroblast and vascular endothelial cells. Granulation tissue derives its name from the slightly granular and pink appearance of the tissue. Each granule histologically corresponds to proliferation of new small blood vessels. Look, each granule of this corresponds microscopically to new small blood vessels, which are slightly lifted on the surface by a thin covering of fibroblast and young collagen. Morphology of granulation tissue. Grossly, granulation tissue appears, it contains a lot of blood vessels, so it's expected to be pink. Yes, it's expected to be pink. The blood vessels are permeable, so it's expected to bleed on touch, and to be moist because of edema, and to be soft because there is no collagen, no nerve supply or no nerve regeneration, because even the nerves that injured in the connective tissue never regenerate, so it's insensitive. Resistant to bacterial infection. Of course, it's resistant to bacterial infection because it's only fibrous tissue. Granular and granular, this is granulation tissue. Sorry, resistance to bacterial infection because there is much blood supply with much inflammatory cells. And we say before that inflammatory cells is responsible to phagocytose any possible bacterial colonization and to release antibodies that fix any bacterial infection. So the granulation tissue is resistant to bacterial infection. Well, histologically, granulation tissue is formed of proliferating new blood vessels, delicate capillaries, proliferating fibroblasts, inflammatory cells, especially macrophages, and loose extracellular matrix. Well, let's talk about wound contraction. Wound contraction accounts for a reduction in size of the defect by the action of myofibroblasts. Yes, the fibroblasts that present in the granulation tissue under certain circumstances and certain cytokine release it's transformed into myofibroblast. And the myofibroblast has the ability to contract. And these contractions help in reduction in the size of the wound. And we need this. We don't need the size of the wound to be big. However, this contraction could lead to complications, and we will talk about it later on. So it may be reduced to 10 to 15% of its original size. This process produces faster healing as the size is reduced. Myofibroblasts account for contraction and represent an intermediate type of cell between fibroblast and myocyte. If there is tissue damage around the circumference of lumen of gut, contraction may cause obstruction. That's what I call it as a complication. Imagine that you have here an inflammation in the esophagus or inflammation in the stomach, and this inflammation turned into scar, and then contracted like this. Look to me, look at the lumen. The lumen is narrowed, is tightened because of this contraction, so may lead to obstruction. Again, burns to the skin end with considerable contraction, and this actually causes cosmetic damage and possible impaired motility. Of course, if the scar is a round joint, like for example elbow, and then the skin here is contracted, this may interfere with the mobility of the elbow joint. Wound strength. Carefully sutured skin lead to 70% of strength of normal skin. 1 week sutures removal, after sutures removal, 10% of strength of normal skin. This will increase over the next 4 weeks, reaches maximally to 70% of normal skin by 3 months. So wound strength to the biggest expectations will be only 70% of the normal skin and begin from 1 week to reach maximally 70% by 3 months, usually not improved beyond this. Why? Why?